Whether you've got stabbing butthole pain, menstrual cramps, migraines, or period poops, you don't have to keep suffering.
Don't let it be normalized. I know that sometimes people will say, oh, that's just periods. That's just everyone deals with that. Don't listen to that. That's not true.
Dr. Karen Tang is an expert on female health and is here to tell you what your symptoms actually mean and why it's probably not just IBS.
So often people come to my office and they're so used to being fobbed off and not listened to that they're like, just you acknowledging that these are real things and that we can do something about them. People end up in tears just from that.
We talk about endometriosis, fibroids, PCOS, perimenopause, plus surprising pelvic floor facts you probably didn't know.
People don't want to sit on the toilet seat, so they kind of just hover their butt over it. That actually can cause pelvic floor spasms.
I'm Dr. Karan, an NHS surgeon, and in this podcast, we sift through the BS of modern health advice and tackle the biggest issues in science, health, and medicine. Today, it's Karen and Karan, and we're delivering a much-needed masterclass on female reproductive health. Pelvic pain comes in many forms, so how can someone get to the bottom of the cause behind their pain? And how much pain is normal? Not only do we chat about the signs and symptoms to look out for, we also explore how to maintain sexual and pelvic health and how to better advocate for yourself when you see your doctor, what children need to know, and much more. So, where should we start? One of the things that I've really weirdly seen a lot of over the years, and I don't know if it's a frequency illusion because I've seen it more online, so I've seen it more in real life, but ever since I saw this video online, stabbing butthole pain, I've seen an increased amount of patients in colorectal clinics that I've done who come in with stabbing butthole pain, lightning bum, shooty bum pain, proctalgia fugax. And I really don't know why I didn't see it that much before. And it seems like a funny thing when you see videos on it or when someone describes it, like a sharp lightning type pain in your crotch or bum hole. And it's actually ruins the quality of life of a lot of people. Is that something that you see quite often? Because disproportionately, it does affect women.
Absolutely. And I think some of this is because of social media. I will tell you some of my most popular videos are on that. And I, stitch someone who had a very viral video, showing their, grabbing their butt, oh my God, and lightning pain in my butt. And I wanted to talk about it because it can be a sign of things like endometriosis or pelvic floor spasm. And most people had never heard this term proctalgia fugax, which is this spasming of the pelvic floor or the rectal muscles. And, it is a fairly common thing. When you look at the comments, there's thousands of comments being I have that too. I had no idea other people experience that. And, there can be actual, serious medical issues causing that. Rectal pain is actually one of the most common symptoms of endometriosis. And because, women's pain has sometimes been so normalized, people have kind of been conditioned to be oh God, I'm not going to talk about this. But it's something that people should bring up with their doctor as, a serious concern.
That thing that you just mentioned, the link between proctalgia fugax being a potential symptom of something like endometriosis, is that because you get most of the time heavier periods during, if you have endometriosis, you might have menorrhagia, which means you might have a greater release of prostaglandin, which could then cause this spasm of the sphincters or the pelvic floor muscles? Is that the underlying link between that shooting bum pain and endometriosis?
There's a few things. And so that could be it, the prostaglandin effect causing cramping, both of the uterus and also of, the bowel. And then also because of just inflammation, one of the most common places for endo to grow is in the space right between the uterus and the rectum. That is one of the most common places. And endometriosis inflames everything near it. The uterus can cause heavier bleeding, the bladder can make you feel urgency, you need to urinate all the time. And then very commonly, it can cause rectal problems, both the pain and that spasm and sharp shooting type pain, but it also causes functional issues. People tend to get really bad diarrhea with endometriosis, really terrible pain. Sometimes even they get rectal bleeding because it's actually grown into the rectum or the colon, and at that point it's actually in those structures and causing severe pain. So all of those things are symptoms that you should take very seriously.
And when you're talking about symptoms to be taken seriously, it wasn't until I really understood more about the pathology and the pathophysiology of seemingly funny things like proctalgia fugax, you realize the full gamut of things which it could, be an indication of. And when you mentioned there that Sometimes rectal bleeding as well could be another, symptom in the sort of constellation of symptoms someone with endometriosis might have. When I was in medical school, I really didn't get a lot of teaching on women's health, particularly endometriosis. And more, I've invested my own personal time into learning about endometriosis. You see the wildest stuff about potential thoracic endometriosis in the
Yes.
diaphragm, in the lung. I don't
Hmm.
see this as a common thing, but I even saw one case report about potential endometriosis in the brain or endometrioid type
Yeah.
tissue in the brain. So really, it's more than just a pelvic condition. It's really a
Yeah.
full body disorder.
Exactly. It can be seen, actually not infrequently in the thorax. Like people
Mm.
can get like catamenial hemothorax. I mean, like, when they have their period, that's what catamenial is, they can get blood in their thorax between their lungs and their chest wall. And, it can be very serious. Like people end up in the hospital, like when they have their period with, shortness of breath, difficulty breathing. And then the bowel symptoms are quite severe. So very often, because they can have such bad diarrhea, the first person that someone may see may not be a gynecologist. It might be a GI doctor. So, especially in the UK, when it's like a referral system to the gynecologist, your primary care or GP may say, "Oh my gosh, you're having so many mysterious bowel symptoms," and then send them to the gastrointestinal doctor. Or if they're getting rectal bleeding, maybe to a colorectal or a general surgeon. So, a lot of times, the first doctor that someone's seeing is not a gynecologist, because some of the worst experiences are actually not necessarily even the menstrual bleeding and that sort of thing.
In a parallel in the GI world where I reside, a common thing which I see misdiagnosed as, well, other things being misdiagnosed as this is irritable bowel syndrome. Over the
Yes.
years,
Mhm.
I've seen chronic bladder infections, gallstones, peptic ulcer
Oh,
disease,
wow.
even endometriosis misdiagnosed as irritable bowel syndrome. And it's only after picking it up on scans or sometimes even a diagnostic laparoscopy for something else like query appendicitis. And you say, actually, no, hang on, this isn't appendicitis, this is endometriosis. And then we
Yes.
refer to other specialties. And I just wonder, how often do you see patients who have gone years being diagnosed as something like irritable bowel syndrome? Because seemingly, so many people self-diagnosed or are wrongly diagnosed by doctors as IBS, and it's actually something serious like a chronic gynecological condition like endometriosis.
Absolutely, all the time. I would probably say, even most endometriosis patients at some point were given an IBS diagnosis.
Wow.
IBS is one of those things where, if you have a lot of symptoms, but we can't find anything, then we sort of say that's probably irritable bowel syndrome. The problem is with endometriosis, you almost always can't diagnose it without a laparoscopy. So if everyone's ultrasounds are totally normal, CAT scans are normal,
Yeah.
colonoscopy is normal, then they're like, well, I guess it must be irritable bowel syndrome, but it's secretly endometriosis or something else that's just not showing up on, the quote unquote typical workup. So I would say actually most of my patients who end up having endometriosis were told at some point that that's what they had. And, the problem is a lot of women's health stuff is like that, where there's no easy diagnosis like an EKG or a blood sugar reading, where objectively you can say, aha, that's it. So very, very often women's health things end up getting put into these, like, you have fibromyalgia, you have, you're like a hypochondriac,
Yeah.
or something like irritable bowel syndrome, which is sort of this catch-all.
So, in endometriosis, one of the classic symptoms, may not be for every single person, but one of the classic symptoms that's well established is menorrhagia, excessively heavy periods, and a lot of pain during the periods as well. At what point does a person draw the line between saying this is to be expected, this degree of pain is to be expected, and hang on, this is actually now way too much, and this is happening on too frequent a basis, and I should probably get this checked out? What's that threshold?
Yeah, that's a fantastic question. I get this a lot. Like, what's the difference between like normal, quote unquote, pain and too much pain? So I tell people it has to do with your quality of life. If you feel like you are not able to go to work, go to school, if you are, having to take more and more over-the-counter pain medication just to function. If you are, say, trying on something like a birth control, it lightens your periods, the cramping is better, but then over time you're like, well, hold on, it's actually getting worse again. You get this pattern of people who are tried on like birth control after birth control after birth control because it just quote unquote stops working. Those are all concerning. And then especially if it's associated with other symptoms. So it's not just, cramping with your period, but you're getting also pain with sex. If you're having bloating, vomiting, diarrhea with your periods, anything that's like very, if you can pinpoint that when you have your period or when you have ovulation, that's the other time that a lot of these flare, that you're having all of these things go haywire, then that is concerning for something else going on. Be it endometriosis, adenomyosis, which is an associated symptom, except it's inside the walls of the uterus, or fibroids, benign tumors in the uterus, but that can inflame everything too. So those are all, little warning signs that there's not just typical cramps. Cramps are normal, but if you're like taking over the counter ibuprofen, you're fine, you go about your day. Most of the time that's just normal cramps.
Now, something like endometriosis is surprisingly common. About 10% of women may have that. But other things as well that you mentioned there, like adenomyosis, fibroids, they're also not that uncommon. Now, is there some link between someone being more predisposed to having multiple chronic gynecological conditions if they have one, similar to like mental health conditions where you're more likely to have two or three if you've got one single one? Is there some connection there? And also, how does someone actually know that, hang on, there's something not quite right in my gynecological health that I should go get checked out beyond just painful periods?
So they do tend to run together. And I will say, I know you talked about this with Jen Gunter. There's such a disparity in research that, for a lot of these, we're like, well, we don't actually know, what causes them, be it a gene or an enzyme, we don't know. And so, but we do see this connection where people do tend to have multiple things. So a lot of times you have endometriosis and PCOS, or PMDD, premenstrual dysphoric disorder. Very often, actually, I find people have all three, the endometriosis, adenomyosis, and fibroids. Endo and adeno very commonly run together. I call them cousins. Like they are relatively similar. They grow up in different places, but they, have some common features. So those very, very often run together. And like I said, I call it the trifecta. There are plenty of patients who have all three. So there's definitely going to be, I'm sure, when we someday find out what causes all these issues, that there may be some link. And then the question of, when do you feel like this is worth getting checked out? Like I said, I always kind of come back to the quality of life. And in the end, even if it ends up not being like pathology like fibroids, I tell people you don't have to keep suffering with it either. So sometimes people will get checked, they have no, fibroids, maybe they even have a laparoscopy, they don't have endometriosis, but they're still really suffering. We say, we should still offer treatment options, even if there's not like a major problem, like with the actual organs themselves. So, the quality of life is probably the most important thing. And that, should trigger a workup. I know in the UK, because it is such a long wait sometimes, to get that referral to a specialist, on the earlier side, really push for that. Tell your GP, like, this is really starting to affect me. I'm having trouble, getting to work. It's so heavy. I'm like, soaking through pads like all the time and changing them really often, or like leaking. Those are things to really push for. And don't let it be normalized. I know that sometimes people will say, oh, that's just periods. That's just everyone deals with that. Don't listen to that. That's not true.
As someone who, once I hit 30, a few years ago, I thought I should start to be more proactive with my health in the sense of maybe getting annual blood tests just to see, how my HbA1c is, my blood pressure, my lipid levels, all of these things. This is not the full biohacking where I'm getting full body MRIs, which I don't want to do, but it's kind of proactive screening just to make sure that, as I'm growing older, there's nothing that is slowly creeping up or becoming deranged and everything seems to be fine. Now, in the sense of being proactive about your own gynecological health as a woman, would you also extend that to maybe getting at a certain age, getting a full gynecological blood profile, like your FSH and your LH and all of these things as well? Would you add that in, or do you think that's unnecessary?
For most people, it's unnecessary. And we tell people a couple of reasons for that. One is that hormones fluctuate so greatly, like, day to day, from part of the cycle to part of the cycle, month to month, that like just like a single level is less helpful than, say, hemoglobin A1C or a lipid panel, where you get more of a like overall picture of your health with just the one number. And it can just either give you false confidence that everything is fine, or, like if something is a little bit off, like it can lead to a lot of anxiety when you're like, oh, if you were just to repeat it like a day later, it might be completely different. Where we do say it's worth getting the testing done if, say, you are, having symptoms of something going on, like you're missing periods, you're, having very irregular cycles, like the time between your periods is completely, sometimes it's 2 weeks, sometimes it's like 3 months. You obviously, if you are trying to get pregnant for a certain amount of time and you aren't, you're not successfully able to conceive. If you are showing signs of menopause earlier than a typical age. So if you're like in your like late 30s and you're starting to, miss some periods, get hot flashes, those are the times where like, let's really investigate what's going on. A lot of people nowadays are coming in to just sort of get checked out for perimenopause because it's been in the news. People have been really speaking out about it, which is great. And what I like to tell people is just how you phrased it. It's about just kind of anticipating and, making sure that you are preparing yourself as best you can for, changes in your life, which are very normal with these, phases, and to really nip things in the bud early. So, rather than waiting until things are horrible and you're just completely miserable, jumping on it as early as you can, or even before you start to have issues. I love when people come in early and they say, let's just talk about perimenopause. Like, what can I do with, exercise, with, like strength training, with all of these things where I can hopefully prevent some of these problems in the future. That is fantastic. I think everyone should do that.
So if someone were trying to better themselves, or if they had something they were concerned about, how best can they advocate for themselves? Because whenever I've made videos online about women's health, I see the comment section inundated with comments from various women from different backgrounds and different countries talking about how they've been gaslighted, fobbed off, ignored, or just misdiagnosed for a number of years. So how can someone advocate for themselves, or if advocate for someone else in their family, whether it's a family or a friend, or a wife or a daughter? How can someone do that to make sure they get the best treatment, or even get second or third opinions?
So yeah, there's many different things I recommend. And so, when I wrote my book, It's Not Hysteria, I didn't want it to just be like, this is an encyclopedia, like here are some facts, but responding to the fact that so often women have a hard time just getting answers, or, how do I advocate for myself with my doctor if they're not listening? So I have an entire chapter on like just preparation for a visit, like, reflecting on all your symptoms so you can kind of have everything ready to go, like when you go to see a doctor. I think part of the problem too is the system where, especially with women's health, I think in the UK as well as the US, like sometimes the visits are very short.
Yeah.
Like could be like 15 minutes. Like the doctor, I know I have friends in the UK who are seeing like 50 patients a day in their surgery or their clinic. And, you want to just make the best use of your time. So coming in there prepared with, I'm having these symptoms, I'm concerned maybe I have PCOS, I'm concerned about my fertility. So having just like that list of, what you're going through, your history, your list of questions, your concerns, just kind of jumps in and maybe helps to organize the visit a little bit. And then at the end, I have a chapter on, what's important to you. Like there's never a right answer for every single person. So a lot of times people will go to these visits and be like, well, your only choice is a hysterectomy, or your only choice is birth control. And then the patient's left like, oh my God, like what are my other choices? I don't love that. So you should always have multiple choices. It's never the case, even for cancer. There's never just one answer. And so if the doctor is only, or healthcare provider is only giving you one answer, knowing that there are multiple answers is helpful. And then also, pushing back a little bit, being like, well, I'd love to hear about my other alternatives. Can you explain about those? And even if one is sort of rising to the top as, making the most sense for someone, they should explain that to you. Like, it shouldn't just be like paternalistic, like blam, you only get one choice and that's it. They should try and explain the thinking behind it. Also, it should never be just like, we have no other steps. Like sometimes people will be like, like, well, they gave me no other, like no workup, no imaging, no, like tests, no, what do we do next? There should always be a what do we do next? Even if we try something, it doesn't work, it should be like, let's try something else. And if they are not giving you that, that's when you push back a little bit, like explain to me, like, what can we do now that this hasn't worked? And if they're not giving you answers, to then ask for, I would really like a second opinion. Can you arrange for that? And again, in the NHS, I think it's a little bit more complicated with getting second opinions, but I know there are ways, I believe, to, push and facilitate like a quicker second opinion. In the US, it's much simpler.
Yeah, no, the second opinion thing, I would say it's almost the system has made people perceive it to be difficult. But like you said, if you just say, I would like a second opinion, there's nothing a doctor can do to refuse that. They are legally mandated to do that. So I think it's actually melting that perception that people, or they're scared to ask for a second opinion because that would offend the doctor or something, and that might in some way impact their care. I think it's actually being brave and saying, I want a second opinion.
That's amazing. And yeah, how powerful is that, just to say that, okay, you actually do have the authority and you should, and you deserve it.
I've often found, whenever I can't quickly treat or quickly fix a chronic condition in a patient, whether it's some chronic bowel condition or chronic constipation, sometimes simply arming them with knowledge seems to do as good as fixing the problem in the first place.
Yeah.
And I guess an example would be talking in women's health, be talking about things like the dysfunction women can have in other aspects of their health when they're during a period. Like, for example, period poop seems to be a very common thing, whether it's period diarrhea, period constipation because of fluctuating progesterone or estrogen levels, pre and post ovulation. They're getting all of these quite significant GI symptoms because of the fluctuating hormones and prostaglandin fluctuations as well. And it's, again, has a huge quality of life impact. But again, explaining why it happens, when it happens, is sometimes enough to just make someone a little bit more at ease with physiology and biology and be like, this is normal and I can correct it by X, Y, and Z.
Yeah, that goes for things like menopause, perimenopause too. Just people being told, oh my gosh, this is actually, it's not just in your head. It is something that is, physiologic. People go through this and there's things we can do about it. I think, so often people come to my office and they're so used to being fobbed off and like not listened to, that they're like, just you acknowledging that these are real things, and that we can do something about them, I think is so meaningful. Like people end up in tears just from that. Like it really doesn't take a whole lot. I'm not like a research scientist giving them like the most like up to date, like, groundbreaking research. I'm just like, I hear you. You are right. You know your body, and these are things that we can try. It is so meaningful, and that's what every healthcare provider can do.
If 55-year-old Stacey came to your clinic to see Dr. Karen Tang today and she felt she had some perimenopause, menopause type symptoms, what are some simple things that she could add to her life today at the end of that clinic appointment that can go some way towards, I guess, making her feel better symptomatically?
The big things we cover, hormone replacement therapy, depending on what their concerns are. And then like lifestyle changes. People oftentimes will come and be like, I've always been really active. Like I exercise all the time, but somehow, I'm putting on weight. I can't lose weight. I feel really fatigued. So there's a whole lot to kind of dig into. I feel like these visits, to do them well, it's like an hour because you're covering like literally every aspect of someone's whole life. And so in terms of the hormone replacement therapy, a lot of the common symptoms, obviously, the vasomotor symptoms like hot flashes, genitourinary syndrome, like all of the, vaginal dryness, pain with sex, bladder urgency, UTIs, very, very effectively treated with vaginal estrogen. And that's something that a lot of the messaging now is about how safe it is. Almost everyone can use vaginal estrogen, like even a lot of breast cancer patients now we know, because so little absorbs into your bloodstream. It's just like a really simple thing. And I just found out in the UK, it's over the counter.
Yeah.
I know a lot of people fought for that. And that is absolutely amazing because it just increases access and affects your quality of life so greatly. You can just go to your pharmacy, pick it up over the counter, and it's very easy to use. So something like that's really simple. We can talk about things like, hormone patches, testosterone. If you're having like a lot of issues with libido, that's an option. At least in the US, I know it's not approved for that treatment, but sometimes people will get the compounded version. But, like the estrogen, progesterone type of hormones is really, really effective for a lot of symptoms. And now we know, we've kind of like dug into the research a little bit. It's not, a lot of the concerns were really overestimated with things like cardiovascular disease, breast cancer. Obviously, we have to individualize it to someone's specific risk of breast cancer and cardiovascular disease, but we're opening it up, quote unquote, to a lot more people. In the past, like, in the early 2000s, when this big women's health initiative study came out and kind of scared everyone, the pendulum swung so far away from hormones. They're like, no one should do it. It causes breast cancer in everybody. And now we have a much more nuanced view. So just giving that kind of conversation about, is there a role for hormones in your treatment? And then just going over exercise. So we want to protect your bones. We talk about exercise, strength training, ensuring calcium, vitamin D, making sure that, you're ensuring the protein, fiber. Like, there's a whole lot of things that we can talk about to help people live their best lives. We can do, like, people used to say, like, oh, menopause, you're like old, but now, I'm menopause age. A lot of us are like, hey, we're still pretty much at the peak of our lives. We want to be active. We want to have sex. We want to, exercise and do the things that we want to do. So I think just empowering people with all of that information.
And I think, it's so important to, I guess, break that taboo, and with the nuanced research about things like HRT, where it doesn't cause the, major risk of breast cancer like some of those flawed studies suggested. It's actually a very small number, and the benefits of the things you get from HRT in terms of quality of life, with increasing or maintaining your bone density and cognition, is so worth it for a significant proportion of women that it makes sense. But not just the medication side of things. And you mentioned there, even other things like even sexual health, exercise to maintain bone density as it plummets during that perimenopause, menopause stage. Those conservative, holistic lifestyle options are so key.
Mm-hmm. Oh, very important. Exactly.
We briefly touched on before about pelvic health and the dysfunction and the close link between GI dysfunction, pelvic dysfunction, and having, any chronic number of chronic gynecological conditions, period dysfunction. What are some actionable things that a woman can do to proactively take care of pelvic health and pelvic floor health?
Yeah, this is amazing. And a lot of people now are learning more about pelvic physical therapy or occupational therapy. I think because there are some pelvic physical therapists who have gotten really big on social media, which is amazing. So when I did my training, I was a fellow in 2009 to 10. And that was like the first time I had learned about pelvic physical therapy, which now I refer almost all my patients to, because it is so common for every woman, person assigned female at birth, to experience some of these issues, be it a problem with the bladder, like having like urgency or having incontinence. Pain with sex very often has something to do with the pelvic floor. And this is both men and women, that very, very commonly there's at least some component of not just the muscles, but the nerves, the signaling, and the physical therapists actually help with all of those things. So it's not even just the muscles, but just all the functions of, your pelvic organs, the muscles, the nerves, your joints, in your pelvis. All of these things can be affected just by, getting older. Like all of us, as we get older, there's more stress on these things. If you've ever been pregnant or given birth, it's not even necessarily a vaginal delivery. Having a C-section, like it's all still very stressful. And going through menopause, because that weakens all the structures too. So you can have never been pregnant, never had any other stresses, and still have pelvic health issues when you're in menopause. I think it's like 75% of, or 80% of like women over 70 have incontinence of some sort. It just at some point gets weak. So, being able to proactively, a lot of countries, I don't know about the UK. I know France actually sends everyone for pelvic PT after they give birth, just because it's so common to have issues. So, in an ideal world, it'd be amazing if we could just send everyone to pelvic PT, just like, you see a primary care doctor, just to kind of, train you, to teach you stretches or exercises to strengthen your pelvic floor, or to, not just strengthen it, but to control it better. Sometimes like the muscles are too tight, you need to relax them and know how to, improve the function. So I actually think that's a great idea. And I send people early on. If they're having like a little bit of an issue, I'm like, it's time to see the physical therapist. And then they can, give you some skills and techniques to go into the future.
Pelvic floor physiotherapists are a game changer. And unfortunately,
Absolutely.
I've referred many patients with obstructive defecation, chronic constipation, and pelvic floor prolapse and various things to pelvic floor PTs. Unfortunately, the problem in the UK with many surgical departments is there's not enough funding to get
Oh, no.
a huge number of pelvic floor PTs. So
Yeah.
whenever I refer them to a pelvic floor PT, there's not that many, and there's also a huge
A long
waiting
wait.
list for patients to see
Yeah.
them. And I absolutely agree, not only in disease states, but actually even when someone is healthy, to maintain that health, there should probably be some community-based pelvic floor PT that someone should just go to, like you would go to your gym PT to, strengthen your
Yes.
muscles and go to the gym. Go to a pelvic floor PT just to improve what you're doing now and to get tips and tricks on maybe why not to hold your pee in, why not to force your
Yes.
pee out, why not to force your poo
Exactly.
out, best position to sit on the toilet. And they are just a
Mhm.
wealth of
Don't hover.
knowledge, like you mentioned, not only physically helping to retrain you or telling you better habits, but doing that sort of organ-brain connection. Because they're just such a wealth of knowledge and just give you actionable tidbits to improve your pelvic floor health. And this is for men and women, not just
Exactly,
women.
yes.
Men also probably could do with some pelvic floor training because, God knows everyone's slowly heading towards pelvic floor dysfunction as we age.
Oh, absolutely. And I tell people this all the time because I think it is just a woman problem.
Yeah.
Urologists, colorectal surgeons, GI doctors all refer to pelvic PT if people, like having chronic, straining with constipation, like pain with sex, like other, pelvic pain and dysfunction. It's definitely not just like a female issue. It's everybody. I was actually just quoted in the Times. There was a great article about me in my book, and the writer had little fun things that she put in there about the pelvic floor that people don't realize are actually potentially causing worse issues. So, she called it the just in case we, or you said that, you pee so often just in case, like before you go, that, it kind of actually makes it dysfunctional. Your brain has difficulty then holding its urine because, you've kind of retrained it the wrong way. Or we talk about hovering over a public toilet. People don't want to sit on the toilet seat, so they kind of just like hover their butt over it. That actually can cause pelvic floor spasms. It's an unnatural position and you're tensing when you're supposed to be relaxing. And people actually can end up with chronic pain because of that. I learned that from physical therapists. They're like, oh my gosh, that's actually a fairly common cause of pelvic pain, that they spasm their muscles because every time during the workday they go to the bathroom, they're doing this crazy, like unnatural like movement. And that is something no one would think of as a cause of pain. They're like, well, of course you're going to hover over the toilet. But all these little things that you could anticipate and prevent all sorts of problems just by teaching someone, how the best way to take care of their body would be.
When I was learning, the basics of biology in men's health and women's health when I was, 14 or 15, and looking at the diagram of the ovaries and the uterus and all of these various things, and you see the lack of detail that's adhered to all of these things. And as you go into medical school, you realize there's a bit more nuance and complexity towards the pelvic organs in both men and women, specifically in women, and then you see it in surgery, and then you're like, hang on, even what I learned in medical school is not quite right because it doesn't look like that in the textbooks.
Right.
And if you look at the ovaries and uterus and fallopian tubes, it looks so wildly different, right? To the neatly packaged angel wings type appearance you get.
The little T shape.
Yeah. And it's more like like some sort of squid in there, right?
Yes. Like little fallopian tubes like flopped
just
over.
flopped over like a wilting flower almost. And
Yeah.
one of the most surprising things that I found out, like an interesting fact, was that, and it was actually an ONG trainee that taught me this. She told me that when you remove one fallopian tube from the left side, for example, the fallopian tube from the right side can sweep across and pick up eggs from the remnant ovary on the left side. And I just thought, wow, these are literally like sweeping tentacles that can go anywhere.
Yeah, it's so funny because that actually was like something huge on social media. Like people were like, we discovered this crazy fact, and it's true. And we tell people this, it becomes important for someone who, say, had an ectopic pregnancy and had to have one tube removed. And in their mind, they're like, oh my gosh, like now my fertility is like halved because I only have half as likely a chance to get pregnant, if I'm ovulating from the other side. And actually, the reality is your fertility actually almost doesn't change at all. Having one functional tube is basically basically the same fertility as having, one damaged and one functional tube. So the other side, and sometimes it's not even necessarily that it's moving that far. Like one of the videos I saw on TikTok was like, it's like walking over to the other side. I was like, it's not like, like walking, but they're so close to each other.
Yeah.
Like they're sitting together very close in the body. Again, it's not like the T with the angel wings.
Yeah.
If you picture two like little squid tentacles, like kind of flopped over next to each other.
It's like two
They're just
paws
so
next to each other
close.
like that.
Yeah. That like the little movements of the feathery end called the fimbriated end just kind of like draws the egg in. It's actually quite wild. It's pretty neat what the body can do. But yeah, most people don't know that. Or they don't even know like that there are muscles. Like that's actually really surprising to people. They're like, there are muscles in your pelvis? Yeah, like the whole pelvis is full of muscles. And a lot of people don't realize that the rectum and the uterus are sitting right on top of each other. Like there's no space between them. In the pictures, there's like this giant gap and like there's this huge cavernous hole and the uterus is sitting in the middle and there's nothing around it. In real life, everything's right next to each other. Like the intestines are all around your uterus. Your rectum's sitting right against it. So that's why when you have problems like fibroids or endometriosis, like everything just sort of gets affected. They're all right next to each other.
If you had to reimagine and restructure sexual education for adolescents and young adults, how would you change things beyond maybe adding some more needed nuance and complexity to things which are dumbed down a little bit? What else would you add?
So number one, telling them about the potential problems. I think because, we get, I don't know how it is in the UK, but in the US, it's very limited. It's like, okay, you have a period, and then if a sperm meets an egg, you make a baby, and that's like it. That's like, you don't get any other like talk about anything. So I think just even the public health messaging of if you're having pain, if you're having really heavy bleeding, if anything is kind of going wrong, that is something to get checked out. Very important. And then also, I had this revelation when I was talking with a sexual health advocate on a podcast recording. Usually, sex ed kind of stuff is so negatively framed. It's basically like avoid infections, which is important. Avoid unwanted pregnancy. Again, important. But she's like, we never talk about like how to have a healthy sex life. And this is so important for, people who are young, like learning issues of like consent, communication, like learning what like your own body, like what brings pleasure for things like, sexual health. A lot of times people grow up with sort of like this fearful approach to their body. Like it's something that, could like explode and like destroy their life rather than, okay, here's how to you mentioned this before, how to take care of your health, how to be as healthy as you can be, both in like, if you want to have a future family, like if you care about fertility, about like sexual satisfaction, like, if you're concerned about, libido, orgasm, like all these things are normal things. And I think they get sort of squashed in the conversation, or even worse, like people are like, don't talk about that. That's like dirty. Just changing the framing around how we talk about sex, sexuality, all these things. So important. You could go on and on. Like there's a million things you could change, but I think those basic things are so key.
I think another thing which really concerns me is how we euphemize a lot of the language around genital health. We talk about sometimes vaginas as lady gardens, front gardens, and flowers, and they're really these kind of sugary saccharine terms. And same for in men's health as well. We
Eggplant
might call
emoji.
instead of instead of the penis, we call it the willy for young children and things like that. And the real thing is, in terms of real life translatability, there's evidence suggesting that it can actually protect against potential sexual assault and sexual abuse if we teach children actual anatomical terms like penis or vagina. So they will be less likely or more protected, certainly, against sexual abuse inadvertently, if they know those real terms. And I think also it's part of maturing and growing up to know that real anatomical terms.
Absolutely. Both like you said, like, here is, this is your body part. And also, like I said, talking about consent, talking about like nobody should touch you without your permission. Like this is not okay. Like so often, especially in child abuse situations where perhaps it's like a relative, someone they know, they're like, well, no one's ever told me that like this person who has authority can't do blah, blah, blah. Yeah. But, just having the empowerment of knowing the parts, knowing what they are, like how you should respect them and refer to them is important. And also it just sets this tone for, later on being comfortable asking for medical care. So for instance, this nurse I was working with just told me her 5-year-old daughter, she got called like by the teacher. I was like, your daughter said a bad word. And they couldn't even say the word. And the daughter had said something like girls have vaginas. And they're like, it's as if it was like the most like shocking and scandalous thing ever, because it's become so like sexualized, and also that there's this implication that like sexual parts are like dirty, or like, the vagina is a dirty word, and then people internalize that. So later on, they may be like, well, I'm not going to talk about my periods. I'm not going to talk about like trying to get pregnant and having sex with my husband. That's too embarrassing, that you should keep that secret. So that leads to a lot of our societal problems with, not giving enough research and funding, because, well, that's just secret lady or sex stuff. Like, why? It's not real medicine. It just leads to this entire culture of shame, of secrecy, of not treating it with the respect that it deserves as like a field of medicine.
And, one thing I wanted to just touch back on was, when we were speaking about advocacy, for example, I
Mhm.
find a lot of the times in Western medicine, we have this mindset where we're trying to diagnose things by exclusion sometimes rather than inclusion. And by that, I mean, we base a lot of our diagnostic abilities purely on scans and tests. This is often epitomized by many conditions which may not have a specific test to pick them up, maybe like fibromyalgia, like endometriosis, where we get a normal ultrasound, we get normal blood tests, we get normal CT scans, normal MRIs, and then we are falsely reassured. And then we falsely reassure patients that everything is normal. And our normal is distorted by just the normality of the tests. But then the patient still has symptoms. So that's not normal
Yeah,
for them.
exactly.
And they're almost, I guess, ushered into thinking that they are the problem because the tests have shown back normal, not the tests are flawed. That's just something that is very interesting to me, that someone could have this agonizingly frustrating problem and everything comes back normal. And
hmm
this is where it really gets worrying, is they then feel that traditional medicine has failed them because they've not added anything to their lives or found out the root cause of their problems. And then they turn to people online who
Yeah.
are promising all sorts
The
of
answers.
crazy out there
Yep.
remedies, supplements, and I don't know, cultish type things. And
Yeah.
that can land them in a world of trouble.
Oh my gosh, that you just made like 4 amazing points. But just to the last one, I think the messaging behind people who are selling just like crazy nonsense on the internet and social media, they are incredibly effective. They are tapping into these, like the anger and the frustration with the medical system. And, if they're sort of saying, well, doctors have failed you, come over here. I have the answer. I'm the only one, but pay me like 200 pounds a month for my supplements and my special courses, based on like no evidence, but the messaging is great. It reminds me of like kind of like the shady people from like the 1800s with the snake oil, where
Yeah.
they're like, this is the answer and it's over here and it's very splashy and the marketing is great and it promises all sorts of things that we can't promise that in medicine because we have to go by evidence. So, I always warn people, if someone is saying, I'm the only one, everyone else in the entire field of medicine does not know and they don't understand, but you need to pay a lot of money to me to get that answer, it's almost always a scam. But back to kind of the original point of, so many things in women's health and gynecology doesn't have a great test. And so I say in my book that, medical professionals are trained to like love objective data. Yes, we can see your blood pressure is high, your EKG is abnormal, your CAT scan showed this. The problem is when all of our traditional tests show nothing and it looks quote unquote normal. Endometriosis, almost always everything comes back normal. Obviously, things like PMDD, like perimenopause, very often your labs are normal and you feel horrible. So, all of these things, it ends up making it seem like the patient is a hypochondriac or they're imagining, they're hyper anxious. And that's why, they're so worried about all these things. And I mentioned in the book too, like it's all about the lens that you're looking at someone. So for instance, very common endometriosis symptoms include like severe pain with periods, pain with sex, bloating, nausea, vomiting, diarrhea, fatigue, migraines. And someone may look at that huge list and be like, oh, that there's not one thing that, explains everything. That's got to be in her head. But those are all classic symptoms of endo. And so myself, an endometriosis specialist, be like, duh, that's a classic picture clinically for endometriosis, and with normal imaging. So again, it all has to do with kind of the lens with which we're trained to look at a patient as a human being, trying to kind of understand if our objective tests are not normal, like let's think about all the things that could still be, and, broaden it rather than jumping right to maybe it's just in their mind.
I think, for anyone listening to this, whether you are suffering with gynecological conditions or whether you know someone who is and you want to help support them or advocate for them, there's such a brilliant way to just have some actionables in their life. And probably, Karen, this is one of the favorite episodes I've ever recorded. So thank you so much for coming on.
That means so much to me. That is absolutely incredible. And also I just wanted to say the Dr. Karen thing, come on, we need to do this again because it's
absolutely
meant to be.
No, but thank you so much.
But that means an enormous amount to me. Thank you so much.
Thanks again to Dr. Karen Tang. Next episode, I'm joined by Dr. Brian Saunders, and we tell you everything you need to know about caffeine, how your morning coffee affects you, when to drink it, how much is too much, why some people claim to be non-responders, and whether you do actually build up tolerance over time to caffeine. Subscribe so you don't miss that and the weekly Dr. Karan Explores podcast. I'll see you spicy meatballs next week.